Okay, thanks, Mahmoud. Welcome for all of you who have joined us so far. My name is Leena Nahata. I'm the chair of the Pediatric Initiative Network of the Oncofertility Consortium. So we are the Pediatric and Adolescent Scientific Subcommittee. For those who are not as familiar with the PIN, we have been in existence for several years now. Our mission is really to protect and preserve the fertility of children and adolescents, and we have really active best practices and research subcommittees within our network. I'm going to turn the mic over now to Veronica, who has served as our research subcommittee lead for the past several years, and she will kick us off and introduce our speaker for today.
Thank you very much, Leena. So I'm very excited to introduce this webinar. It's a little bit different than what's been done before in the Oncofertility. As Leena said, I've been part of the leadership of the Pediatric Initiative Network since it started, and I'm the head of the research subcommittee for that PIN. I have been working, I've had the pleasure of working with Dr. Kayiira from Uganda for approximately a year now. And I know that both Mahmoud Salama and Teresa Woodruff really wanted the Oncofertility to encompass not just high resource areas and not just the United States, but the rest of the world. And Dr. Kayiira is doing some really exciting work around fertility preservation in Uganda, and I think has some lessons for other low resource settings. He will introduce his background. He's a reproductive endocrinologist, but I think this is really important work and definitely something that the Oncofertility Consortium is very, very interested in continuing to stimulate and move forward. So with that, Anthony, I'll hand it over to you.
Thank you, Veronica. So welcome you all to this webinar on the status of pediatric oncofertility in low to middle income settings. I'll be presenting a Ugandan case study. And as I introduced earlier, my name is Anthony Kayiira. So we will mainly look at my profile, a background about oncofertility in a world as a whole and in low income settings. We will talk about childhood, adolescent, and oncofertility in Uganda. We'll talk about the URHSPY project and the components within this project and the results which we will share that underpin the case study in Uganda. So I'm born in Uganda and I did my MD in Uganda, my residency training in obstetrics and gynecology in Uganda. I did my clinical embryology MSc in Oxford University. I'm board certified by the American College of Embryology. I've just completed my postdoctoral fellowship in global health research with the Fogarty International Center. And I am currently an IVF lab director for the National Referral Specialized Women's Hospital and my fertility unit. I offer teaching support to a university and I've a copy eye on several grant-funded projects, for which one of them I have just completed, the Understanding Reproductive Health Among Survivors of Pediatric and Young Adult Cancer this year. So many members in the attendance today will testify to the fact that there's been an increase nearly about 12% over the last 3 decades of cancer diagnosis among children, those aged 0 to 19 years of age. In sub-Saharan Africa, a corresponding increase in the last 2 to 3 decades has been seen, now at about 50 to 150 per million children per son years. Unfortunately, this is slightly lower than the global average because of the underestimation resulting from limited access to diagnosis, treatment support, follow-up, and insufficient registry systems. In Uganda, we currently estimate the incidence to be at about 139 per million children aged 0 to 19 years of age. And the commonest cancers currently diagnosed are non-Hodgkin's lymphomas, Hodgkin's lymphoma, Kaposi sarcoma, leukemia, Wilms tumor. The 3-year survival rates in Uganda are only improved recently. So as of a study published in 2019, the 3-year survival for Hodgkin's disease was at 86%, which is the highest survival we have for childhood cancer. And the lowest was in Wilms tumor, which is at 30%. We do currently lack 5-year survival data, but a paper from Howard and Lam did estimate that in sub-Saharan Africa, the 5-year survival is quite low, ranging between 20 to 40%. This is quite much lower than what is actually currently estimated in the high resource settings, which is 80 and 90%. And the main reason for this disparity is mainly differences in early detection, efficiency and efficacy of treatment modalities, availability of various efficacious treatment modalities, toxic death from the treatment, supportive care, and loss to follow up. So because of the increasing survival in global survival rates in childhood cancer, and the currently much better survival rates in low-income settings like Uganda, we're shifting, or the world has shifted already, look from the cure towards connecting to quality of life among survivors. And here we are looking at the potential long-term effects of the cancer itself or its treatment. And we do know that the late effects could potentially affect reproductive, endocrine, pulmonary, central nervous system, skeletal, and even subsequent neoplasms. In high-income settings, it has been shown in several studies that reproductive concerns do carry a significant or higher rank among worries or expectations among childhood and adolescent survivors. These late reproductive effects that we have that have been published before include delayed puberty, and I can say this depends on when the gonadotoxic treatment is received by the adolescent or the child. So it can be delayed puberty in case of those who receive it in the pubertal ages, premature ovarian failure among adolescents and young adults, testosterone deficiency, impaired spermatogenesis, sexual dysfunction, infertility, and pregnancy complications. In sub-Saharan Africa and in Uganda, there is little data about these late reproductive effects in terms of prevalence and burden. But we do know that the several international societies that are concerned with fertility preservation among cancer patients do recommend discussing fertility preservation during oncology care. But for many studies in high resource settings and low resource settings, it has been shown that this is rarely effectively attended to. Regardless of context, infertility as a disease and as a disability is associated with significant psychological distress. Importantly, in Africa, because of the unique cultural and social context, women who suffer from any form of infertility, whether brought on indirectly by drugs or by any other cause, have a disproportionate psychological burden, which can include stigma, ostracization, intimate partner violence, depression, anxiety, and some incidences of suicide. So childhood, adolescents, and young adult infertility in Uganda is something that I have taken, and my team have taken quite seriously because of the global increases in survival rates, not only in our country, but in countries nearby, and the fact that part of fertility as a right of any individual needs to be well addressed. Unfortunately, in Uganda, no Oncofertility cancer survivorship program exists. There's limited awareness about the long-term effects of cancer treatment. We don't have any contextual data regarding the burden of reproductive failure from among our survivors, and we don't know the institutional, parental, provider perspectives towards these long-term effects or addressing them. So we designed the URHSPY, which stands for Understanding Reproductive Health Among Survivors of Pediatric and Young Adult Cancer Project, which was funded by the NIH under the Fogati Global Health Fellowship Program. So we did a mixed method kind of project, and one part was to conduct a computer-assisted telephone interview or survey among those survivors who were diagnosed between the ages of 0 to 25, and we're mainly trying to estimate the burden of reproductive failure among these, and to describe their attitudes towards fertility and the experience of oncofertility aspects during the time when they have the cancer and receiving care. We also conducted an in-depth interview among parents of children with cancer to try and evaluate or try and describe the experiences, attitudes, and perceptions as they were interacting with their healthcare providers and their children during which their child was being treated. We also conducted an interview among healthcare workers to try and navigate their concerns on future fertility among children under their care. One of the first sets of results was to understand fertility attitudes and outcomes among survivors of adolescent and young adult cancer survivors in Uganda. So this was the computer-assisted telephone interview, which is abbreviated as a CATI-based survey. So in Uganda, the Uganda Cancer Institute provides, if not 90 to over 100% of the cancer care. And many of the patients who receive care in the Uganda Cancer Institute are registered in the Kampala Cancer Registry, which is the oldest curated complete source of cancer incidence that we have in the region. Many of these data would include the date of diagnosis, nature of the diagnosis, treatment received, and follow-up for survival. We did look at the time frame between 2007 to 2018 because it seemed to have a bit of most of the complete data. We looked at those diagnosed between 0 to 25 years of age and were alive at the time of last contact. So we screened the registry for eligible entry. We traced the participants. We conducted the red cap-based survey, and we did the analysis. So only about 11% of the those diagnosed between 0 to 25 years were eligible. Eligibility meaning the fact that they were alive at last contact and that there was complete information to be able to trace them in the registry. We attempted to contact the 259 potential participants, but we had a very low response rate, which was at only 34, which is 13%. And the main reasons were the fact that we couldn't reach some of them. We had wrong numbers. Some numbers had been disconnected. Some had died subsequently, either from the cancer or other indirect causes, and some had been misdiagnosed. Of the 34, 14 were female and 20 were male, ranging ages between 18 to 34 years, with the median age of males slightly lower at the time of the survey at 23 or 24 years compared to females, which was at 28. The median age of diagnosis for males was at the boundary between adolescence and young adulthood, which is at about 17 or 18 years of age. But the median age for the females was within the young adult range at about 23 to 24 years. Most of the participants were survivors of Kaposi's sarcoma, which contributed to about 44% of diagnoses. Other diagnoses included Hodgkin's lymphoma, Williams tumor, rhabdomyosarcoma, squamous cell cancer of the skin, and others. 94% of these survivors had received only chemotherapy. And the regimen that was prescribed mainly for Kaposi's sarcoma was bleomycin and vincristine as first line, and addition of paclitaxel as second line. One of the main areas of the survey was to try and evaluate the recall for the oncofertility discussion, if there existed any during the time when they had the cancer. 7 out of the 34 participants recalled having had some form of discussion about fertility, but none of these discussions had resulted into referral to a fertility specialist or a gynecologist. 25 out of 34 of the participants did find that information received or the discussion they had during the time when they had the cancer about fertility-related issues was inadequate. Among the fertility outcomes, because we did try to assess the burden, although we had a very small sample of 34 out of 259, 6 out of 34 did meet the criteria for infertility. And here, our definition was having a partner in a heterosexual relationship, intercourse in about 3 times a week for about a period of 12 months, with a desire to have a child and lack thereof. 3, that is 3 among the females and 3 among the males did meet this criteria for infertility. And this is slightly higher. 18% is quite slightly higher, although the sample is quite small, than the background prevalence of secondary infertility in Sub-Saharan Africa, which is at 11%, or primary infertility, which is at about 1 to 2.5%. Only 5 out of 14 women did have a pregnancy subsequently, or a first pregnancy after they received their cancer diagnosis. When we looked at the attitudes, all the males and the females participants did desire to have at least 4 children or more, and many thought they would raise the children that they would want. Many were not satisfied with their lives if they were unable to have children. Many wanted to have a biological child. The comfortability with doing assisted reproduction varied, with more likely to be comfortable with assisted reproduction among the males and slightly a little bit more, but not as much among the females. Many of them were undecided about their comfortability with adopting children in both males and females. The limitations of this study were, by extent, some of the limitations of conducting survivorship research in low resource settings. Many of the times we have lost to follow up insufficient registries, inconsistent information, unreliable telephone contacts, hard to reach areas, and poor survival rates, and also limited life expectancy, which can indeed impact survival rates because of deaths from other causes other than the cancer itself. And this particular study lacked a comparison group of adolescent and young adult survivors, persons without cancer, for which to compare, fertility attitudes, and so to make inferences that could be valid for other populations or comparable. So we concluded that adolescent and young adult survivors do have lower fertility rates compared to the background, despite the fact that they have a strong fertility desire. Information and counseling about fertility-related problems was insufficient in this population. The second phase of results looked at the results in theme for the second phase of results was that shared decision-making about future fertility was very important in childhood cancer survivorship as per the perspective of the parents of these children who have cancer. So as initially presented in the previous slides, the Uganda Cancer Institute does provide nearly all the care for childhood cancer patients. And we did look at parents who have who had children 0 to 19 years of age, 18 years of age under active but less intense care, and at least these parents were 18 years or more. We conveniently sampled these parents and did face-to-face semi-structured interviews and did thematic analysis. So we reached saturation at 20 participants, and among these 16 were female and 4 were male. The average age of the parents was 35 to 36 years of age. Majority of them were parents and few of them were guardians. Out of the 20 participants for which we reached thematic saturation, 10 of the children with cancer were male and 10 of them were female. So when we looked at the data comprehensively, so what we did, we asked questions using a grounded theory approach and inductive coding to try and assess anything that could arise about perspectives, attitudes, and experiences. So we asked about the cancer journey, we asked about interaction with the health workers, interacting with their child, the short side effects, issues about long-term side effects, fertility desire, to try and see what kind of meaning we can get out of this particular phenomenon, which is net effects of cancer relating to fertility among these children and how their parents perceive or experience this, or what are their attitudes towards this. So what came out as a global theme was shared decision-making being very, very important. And among these, the major theme was importance of accurate information, for which we had people saying they like a thorough medical explanation, and they felt that the information about fertility was inadequate. They were afraid to ask. They wanted the right information at the right time to the right audience. They wanted fertility preservation options. They also desired respect of autonomy and to be more inclusive of the child in terms of participation. They encouraged and wanted more engagement and psychological support. They also found the insufficient doctor-patient ratio and needed more partner support. So what I will present here was I will present snippets of the themes and supporting quotes. I think they're quite in detail, but I think I can actually go through one of them. So for the importance of accurate information, this was a very good quote that we thought would be representing this theme. One of the parents said, I have had some rumors of this from other parents, but the doctor did not discuss with us anything about that. All I would want to know is that your child, the sickness has reached here and there, but the reproductive part may have some challenges in the future. Although I'm looking at the life of my child, I do not like the feeling that information from the corridors and not from the doctor. I would love the doctor to come and tell me that from chemotherapy, your child may not have children or have children. I would love it to come from the doctors and not rumors from other patients. This is a patient trying to bring to the surface the value of accurate information and the information coming from the doctor. And the fact that rumors do cause increased anxiety. And especially as we talked about earlier, the value of reproduction and fertility in our society. such rumors, if unfounded or founded, could cause significant anxiety in the parent and extend to the child or affect future satisfaction with care. The next was respect of autonomy, and this is the supporting quote. You should do this thing by first sitting me down and telling me everything about the diagnosis. Tell me the treatment may go this way so that my child may be affected in reproduction. Allow me to think about this and ask me if I agree that my child receive treatment. Ask me how I would feel. Say my child gets treatment and fails to have children in the future, so that I can think about it and decide if my child gets treatment. If I refuse the treatment, let my child be this way and die or give birth in the future. Let me decide that too. But I do not think anyone can reject life-saving treatment for their child, but we need to know and decide. This particular participant was bringing to the surface the fact that they would like to have some level of choice in which is based on the information that you actually receive about the pros and cons of treatment, and that they would feel more involved and more likely to accept the outcome if they knew about it and they decided knowingly. Because indeed, the chemotherapy is life-saving, but the parents wanted to know all about the treatment before they received it, so they could feel more involved and more in power to deal with the resulting consequences, if any. Then for engagement and psychosocial support, this is the theme. The supporting quote. I think maybe you may not have the time, but the mothers go through a lot. They are worried about their child's life. Rumors about dangerous chemo in the corridors of the hospital. We simply do not know anything about reproduction after cancer. Everything is moving too fast and we feel all alone. Health workers need to engage us more. Talk to us. Tell us more about the treatment. Ask about our worries. What have we had? Even if our children won't give birth, do not give up on us. Follow up our children. Run some reproductive tests. All we need is more time with us. So this is one that raises the issue about more engagement, not just at enrollment, but also throughout the care continuum, even after the cancer treatment intensive and maintenance phases have been completed. And this they felt was so important to them in enabling them to make decisions about the care of their child, especially regarding fertility. So one of the limitations is that, of course, this data is quite unique in that the parents are those who are in Uganda of children who have been diagnosed with cancer receiving treatment at Uganda Cancer Institute. It may not represent parents' perspectives in other settings, even within the same country, but it's something that I think can be comparable in other areas in terms of what actually adolescents feel and worry about when they're having cancer treatment. The convenient sampling method may reduce the variation or the level of variability within the sample, and as such, selection bias could have had an impact on the kind of participants that we enrolled, the content that we got, and the themes that we derived. So parents in low-resource settings value a multifaceted model for a satisfactory decision-making process within the context of child reproductive survivorship. There is a need, there's an obvious need for build capacity for oncofertility resources within the region in order to empower both the parents and the healthcare providers to address, not only to address oncofertility in children in terms of providing the necessary resources, but also to address the skill set needed to engage parents and health workers with a satisfactory oncofertility experience in our setting. So in some of the areas for future research, of course, we need to look at the perspectives and experiences among adolescents. We have not presented the data from the health workers because it's still under analysis. We need a robust registry for pediatric cancer and follow-up. We need to look at more cost-effective, resource-sensitive, and adaptable methods of fertility preservation for our setting that can be scaled out much easily, considering the financial and the resource constraints. In terms of collaboration, of course, there is need, as you can see, for setting up a cancer survivorship program, more so in children with cancer. We need to build capacity for a robust database. These areas for potential collaboration with the North-South is very important here. Collaboration in establishing low-cost and content-specific fertility preservation technologies, support for long-term reproductive tissue storage capabilities. For example, we could be able to provide the training and skills for people to do ovarian tissue harvesting. But in terms of resources for long-term storage, we may need maybe use of cryo tanks in other settings or other areas if there's some form of collaboration that is involved. Also, they need to add to the pool of existing data on fertility outcomes among childhood cancer survivors, not just in the resource rich settings, but also in low resource settings, and to draw comparisons. And from these, we can have comparing areas of low resource in different communities, even in the United States, from which you can draw some of the similar perspectives and design interventions that could be scaled up, not only in our setting, but in different settings. So I would like to acknowledge Veronica Gomez, who's the moderator for this webinar, but also my mentor, and has been strongly pivotal through the 1 year of this fellowship. I recognize Jennifer Neda John from University of Stanford, Doctors Daniel, Serena, Joyce, Henry, and Rahel, who are part of the research team for the URI HPY for this 1 year of the fellowship, and really been very grateful in trying to arrive to the data that we have. Thank you so much, and I will invite questions now. Thank you.
Thank you so much, Anthony. I'm fascinated by this subject, and I think it's very, very important that we begin to gather this data. I think what's really interesting is some of the things that you're finding are the same things that we have found in high resource settings, that families want to hear about this. I think we often make assumptions that people in other medical systems and other settings may not want as much information, but here we heard this again. One of the questions that came to me directly was about the chemotherapy. The agents that these patients received are not as gonadotoxic as some of the ones that we think of as high risk. And I think you and I have had this conversation that many of your patients had Kaposi sarcoma, and there's this shifting demographic in what kind of cancers patients in Uganda have. Do you want to talk a little bit about that?
Yeah, so if you look at the sampling timeframe that we used, we were unable to, most of the participants for our survey, had to be at least 18 years of age. And so looking at those who are 18 years of age, they needed to have suffered from cancer maybe a little bit at a much earlier timeframe. And when we sampled between 2007 to 2018, many of our survivors turned out to be currently, at the time of the survey, a little bit older. So they had suffered from cancers that were, of course, significant burden, like HIV-associated tumors, like Kaposi sarcoma. At the time in Uganda, when the scourge was really at its peak in terms of epidemic levels. So many of them had suffered from Kaposi sarcoma and had received treatment. Unfortunately, at the time, even survival rates for other tumors, like Hodgkin's disease, acute lymphoblastic leukemia, rhabdomyosarcoma, Wilms tumor, and Hodgkin's lymphomas were very low. So if you sample within that time frame, in order to get people who are at least 18 years of age now, you will find that most of them did not make it, who had any other tumor other than Kaposi sarcoma, which is highly curative in case the person received highly active antiretroviral therapy and the effective regimen of vincristine, bleomycin, or paclitaxel for second line. So because of our sampling time frame, it gave us a unique a unique proportion of individuals who many had suffered from Kaposi sarcoma. But currently, the survival rates for other tumors, as you had seen in my presentation background, like Hodgkin's lymphoma, is now at around 86%. So if I was to repeat this maybe 5-10 years from now, the proportion of individuals with different tumors would definitely be different. And we'll be looking at different answers from the questions that we asked for the survey. Unfortunately, we had to start somewhere, and we started at that time frame. But we look to do this more and more often, so we may get a different perspective than this. Thank you.
Well, I think you're starting at the beginning, whereas we started at later in our resource settings. By the time we started doing this, people had very high survival rates. I think it's very nice that you're doing this concurrently. I know that we had one comment. This is a wonderful study, very thorough, and great job, Anthony. Anybody else have any questions? I think one of the other things that we have really discussed, I mean, Anthony's really getting the perspective from what are the outcomes, what do the parents think, and then what do the providers think. But he's thinking ahead, and as he mentioned in his last slide, he's thinking about if fertility preservation is important, which it looks like it might be important, you know, how can you do for, you know, we are already struggling with ovarian tissue freezing and how to store the tissue and the expenses. How do you do that in a low resource setting? Do you want to just mention a little bit of some of the things you're interested in doing in the future?
Okay, so because I'm really quite keen on fertility preservation in young cancer patients, I did try to find out initially, like from the study, as you can see, what is the current, you know, status analysis or situation analysis. And indeed, the people do desire it, but we do have to have a cognition of the context which we are in. And if you look at the skill set and the resources involved in some of the papers that have been published by the Oncofertility Consortium on the minimum requirement for setting up an oncofertility kind of program, some of the resources may be out of reach in terms of a commitment within our setting. So I've looked at several technologies for fertility preservation or for tissue freezing, with something called dry freezing. So the Smithsonian Institution of Conservation Biology has been looking at ways of doing supra-zero freezing of tissue among feline and canine models to try and compare it to cryopreservation with liquid nitrogen. The studies are still within their primary stages in terms of phase 1 trials, but the data looks promising. And if they can actually fine-tune the protocols, maybe it is possible to do dry freezing. Because in nature, if you look at hibernation in crustaceans, they do some kind of dry hibernation method where they reduce their metabolic rate to almost zero and are able to keep this dry, desiccated state for very long periods of time, despite the ambient environment or temperature. So they're trying to borrow from this kind of existing model to try and see if they can have traction for this in animal models and maybe in the future. So we're looking to have that as one of the arms of our future in terms of future projects to look into. If we can actually have that done in our setting, and if we can find that it is effective, maybe we can have something that is, you know, a context specific within our setting, which is the low resource. Thank you.
Yeah, I was fascinated when you first brought that up to me, the idea of dry freezing. I think it's something that maybe influences what we do even in high resource settings. We did have another question from Jesse Long, one of my fellows. What are families usually told in Uganda when a child is diagnosed with cancer? I know, you know, I'm from South America. Many years ago, I sort of learned that in South America a lot of times, and I don't think this is what happens nowadays. Many times the patient is not told about what's really happening. They're just given, they're just told they need this certain kind of treatment. So what are they told? Because based on the parent's perspective, it seems that they're not getting full information. What is your sense of that, Anthony?
So I have actually worked as a reproductive endocrinologist in an oncology setting, that is at the Uganda Cancer Institute. And I had to actually, you know, force myself into the clinical consultations because initially doctors didn't feel that I was supposed to be there because they thought I'd scare the parents away and the children won't have treatment. So what I observed, and one of the reasons why I actually wrote up this paper or this project, was that they're not told much about the diagnosis. It's more about your child has a condition, the child needs treatment, the child needs a cure, the child may survive, the child may not survive. Nothing more about that. And so what is undergoing in the mind of the parent at the time is all about survival. And in such a setting, they kind of lose a perspective of other things that can result from this. So it's not a case where the doctors really intend to give less information. Some of the health workers actually don't even know that there are actually any long-term effects for this, as we shall see in the papers that we publish about health worker perspectives. Some know just a little bit. Some think that some cancers may be, or treatments may have an effect and some may not. So we have an issue where there's no or lack of information, not only in the provider, but also the parent, and of course the child, who's rarely involved in these discussions. But looking at how the survival rates are improving, we're going to look at situations where more and more children who survive cancer have some form of fertility problem. And many of the time we'll be able to trace this back. And you feel as a clinician that you failed the patient without looking into their long-term outcomes. And that is exactly what it is right now. So we hope from the data we publish, we're able to raise awareness and advocacy for this, that we can have guidelines in cancer control programs that do consider survivorship, especially late effective reproduction, as a major component of quality of care among survivors, especially children and adolescents.
Thank you. A different question. What are the costs your patients endure for their preservation? So what are the options first in Uganda at this time, and what are the costs?
So currently in Uganda, in terms of options, we have mainly egg freezing or oocyte freezing and embryo freezing and sperm freezing. But you can see this is not as oncofertility. It's more fertility preservation for social reasons outside the realm of oncology. So these you will find in private clinics. In terms of what undergoes in the discussion for fertility preservation for oncology reasons, this is not discussed, as some of the health workers don't know about it, and the parents do not know about it. So what is available in terms of preservation generically is oocyte freezing, embryo freezing, and sperm freezing. In terms of things like tissue, which now actually has been no longer experimental, but actually in terms of the guidelines for ovarian tissue freezing, we don't have the skill set. Although we may have the cryobanks, but the skill set for ovarian harvesting, processing, and preservation, we don't have that here. In terms of cost, the cycle, a particular cycle, so now we're looking at maybe young adults and people who are a bit older within the age group that is accessing social freezing. In terms of cost, it costs about $5,000 US to go through a cycle to generate oocytes, or which may be fertilized. You get embryos for freezing. And every year they pay an equivalent of about $400 to maintain the storage process until they thaw them. Sperm freezing costs about $200 one-time payment, which will include 1 year of freezing, and then subsequently $400 each year for any year of storage until thawing. So the costs are quite limited, because if you look at the average income of in a year of most of the Ugandan patients is about maybe $1,000 to $2,000. So many of them can actually afford. And if you look at the financial toxicity associated with oncology care in terms of the parents, the time the parents spend away from work, away from home, and the cost of the supportive care, even though up to 80% of the care is paid for by the government, if you had to add this burden of fertility preservation, that would be, a little bit more significantly challenging. But we need to talk about this. We need to discuss this. We need to look for potential solutions to this, because it's actually very important. Can we have grants funding this? Can we have some organizations that are really interested in helping these cancer survivors? Because we need to start the conversation so we can address the challenges. And I think one of these papers describing the state in Uganda really brings to surface some of these key components of survivorship among adolescents and young adults. Thank you.
Yeah, a lot of food for thought. I think it's important to bring this attention. So Leena asked, are there plans to improve provider training education?
So this was the first set of papers that we had released. They are quite novel. We are now currently doing workshops at the Uganda Cancer Institute just to try to present the data so people know about this. And we are currently engaging with the National Cancer Control Program to incorporate survivorship, especially in vulnerable populations for cancer, in that as part of their national policy. So there is funding that is allocated towards this, not only for training, but other resources. But in such settings, it's always a process, a lot to look forward to. And many times, once you rely a lot on the government to provide this, you never get to where you're going. Hence, the need for collaborations with partner institutions or people who think of a like mind, and we see if we can get there. Maybe if we have a sort of a model that we can have that the government can look at and see the success, maybe from that, they can look to invest more money into it.
Thank you. There's a question from, or a comment from Dr. George Moses Awengo, said, excellent presentation, Dr. Anthony. I'm quite happy you're breaking the ice. We shall need a lot of awareness as we start. I have a challenge in Nairobi, Kenya, even to start introducing the clinical oncologists to embrace oncofertility. Cost is also a big factor as we speak. So I think your work is really going to start, it's going to be very inspirational to people in other countries. One question from Gina is, does the government help with costs of family fertility preservation?
So currently, the government only offers partial alleviation of cost for cancer treatment. And because, of course, fertility preservation is not something that is being mentioned within the oncology fraternity within the country. So the government doesn't even know that it needs to support fertility preservation yet. And that's where the kind of the steep incline is for us to try and get the stakeholders involved to understand that this is something that needs to be addressed. So for now, the government is not providing any form of fertility preservation support, not only generically, but also for oncology patients. The government doesn't fund assisted reproduction in the country. The government is planning to set up the first, I think, public hospital for IVF, for which I am helping the government to set up, but it's not going to be for free. It's going to be at a cost, of course, subsidized, but still at a cost. So for now, no, it does not provide any kind of financial support for oncofertility.
Which is a problem we have here too. I do want to make an announcement to anybody who's on the call that the NIH and the Fogarty International Center, in partnership with African Academy of Sciences and the Bill and Melinda Gates Foundation, has announced that they're accepting applications for the African Postdoc Initiative. So there are these opportunities to do research and for mentorship in combination with international institutions. If anyone's interested, you can email me. It's a very intensive program. I know Anthony and I have discussed it. Let's see.
I just wanted to take a moment, Anthony, I really want to congratulate you on taking this on. This is obviously a huge endeavor, and you have a lot of barriers. I just want to contextualize it and say that, it wasn't that long ago where many of us here were facing the issue of buy-in from key stakeholders, right? I remember during my fellowship, 10, 11 years ago, when I was trying to do this work within the pediatric oncology setting, there was a lot of concern from the pediatric oncologists. This isn't the appropriate time to be having this conversation. The family is overwhelmed. We think that we need to defer it. And it really took a lot of research and then guidelines to say that, people are feeling distressed, and families are actually saying that they wish they would have gotten this information, and that getting the information actually provided them hope. And that really is what was needed to move the needle. And I still think people face these barriers at some places. So I think you're doing the absolute right thing by collecting the data directly from patients and caregivers, and then publishing it to inform guidelines to raise awareness.
Thank you so much for that, Leena.
I don't see any more questions, but I have to ditto what Leena said. I mean, I remember when I first started wanting to do ovarian tissue freezing at Children's National, the IRB thought I was crazy. And talking to the oncologist, they kept saying, no, these families have a child who might die. They are not interested in hearing this. So we were hearing these same things not that long ago, about 10 years ago. I think there's much increased awareness of oncofertility. So the idea that this should only exist in the high resource setting is just not fair. So I'm really glad that you're pushing for it in your resource setting and with a cultural sensitivity to your individual setting. So congratulations.
Yeah, thank you so much. Thank you so much, Veronica.
So I think with that, we've concluded our webinar. Thank you, everyone, for participating. Thank you, Anthony, for stirring this. So bringing the subject to everyone. This will be posted in the Oncofertility website. So it's going to be a big resource to inspire people, I think.
Sorry, I didn't get the last thing you said, Veronica.
I think I might have frozen, but thank you very much to everyone for
Okay.
participating. And I think this will be very inspirational for everyone.
Thank you. Thank you.